LQB285 Eleisha and Ashleigh Finlay. Non-modifiable risk factors that have contributed to his respiratory systems include being over the age of 65. There is a marked variation in the effect of aging on lung function. Aging is associated with a reduction in chest wall compliance and increased air trapping. The decline in FEV1 with age likely has a nonlinear phase with acceleration and rate of decline after age 70 years. There is an increase in airspace size with aging, resulting from a loss of supporting tissue. Respiratory muscle strength decreases with age, however the respiratory system reserve is limited with age, and diminished ventilatory response to hypoxia and hypercapnia make it more vulnerable to ventilatory failure during high demand states, for example heart failure or pneumonia, pertinent in Patrick's case as he has left-sided heart failure. Another factor that's contributed to his respiratory systems is left-sided heart failure. Left-sided heart failure increases the end-systolic volume, which therefore increases systemic vascular resistance, leading to an increased left ventricular contraction, leading to an increased left ventricular oxygen demand, causing left ventricular hypoxia, causing decreased force of left ventricular contraction, leading to an increased left ventricular and diastolic pressure, leading to increased left ventricular preload, increased left atrium preload, causing pulmonary congestion and pulmonary edema. Modifiable factors that have contributed to his respiratory systems include BMI and waist circumference. According to the Australian Heart Foundation, regardless of your height or build, a waist measurement of greater than 94 centimetres for men is an indicator of the level of internal fat deposits which coat your heart, exacerbating Patrick's left-sided heart failure, therefore exacerbating his respiratory symptoms. Smoking is a modifiable factor that has contributed to his respiratory symptoms. Due to the repetitive and toxic injurious stimulus of smoking, the repair and remodel process that heals damaged endothelial linings become impaired, leading to an extended damage to the airways and alveolar, causing impaired gas exchange, evident in Patrick's respiratory symptoms. Factors that have contributed to his heart rate include hypertension, increased LDL levels, increased potassium, increased triglycerides, increased VGL, and smoking. Hypertension causes systolic failure, which decreases cardiac output and increases heart rate. An increase in the presence of low-density lipids in the blood increases the buildup of plaque within the arteries and subsequently increases the chance of plaque sticking to the arterial walls, creating atherosclerotic plaque. As the presence of atherosclerosis increases, the space for the blood in the arteries decrease. This limits the supply of oxygen to the necessary tissues, which causes a chain reaction in order to supply a sufficient amount of oxygen to the body. To increase the supply of oxygen, the body does a multitude of things. It sends signals to the heart telling it to pump harder, thereby increasing blood pressure so the blood can get past the atherosclerosis. The medulla oblongata stimulates a respiratory response, hence increasing the respiratory rate and to gain more oxygen in the blood. As a result, the contractility of the heart also increases to compensate for the increase in blood pressure and respiratory rate, as seen in Patrick with his blood pressure of 135/85 and a heart rate of 155. Potassium is important for maintaining electrical signals throughout the body, namely the heart muscles. When potassium levels increase in the blood, the electrical impulses sent from the sinoatrial node also increase. This causes an increased contractility of the myocytes, and thus an increased heart rate can be seen in Patrick. Smoking increases blood coagulability, making it harder to pump around the body. This causes an increase in blood pressure and thus heart rate in order to maintain sufficient blood supply. Smoking also increases the risk of atherosclerosis, which blocks the arteries, thereby decreasing blood and oxygen supply to the body tissues. This causes an increased effort in the heart contractility and ventricular pumping. Left-sided heart failure and COPD risk factors include smoking, age over 65, and being overweight. Patrick's COPD most likely developed due to his 40-year smoking history. Smoking causes free radicals to be produced in the lungs and the inactivation of lung antiproteases. Combined, these lead to lung inflammation due to an increased oxidative stress and presence of inflammatory cytokines and protease function. Smoking causes continuous and repeated injury to the bronchial tree. This leads to infiltration of neutrophils, causing inflammation and narrowing of the airways, increased goblet cell proliferation, otherwise known as increased mucus production, and the death of airway epithelium ciliated cells, which subsequently trap the mucus in the airways. Smoking also increases proteolytic deconstruction of lung parenchyma. This leads to decreased airway elasticity, thereby trapping air within the lungs, decreased structural support for the airway, narrows and collapses the airway, and finally it leads to permanent enlargement of the alveoli, which causes hyperinflation of the lungs and increased presence of bulbae on the lung surface. Patrick's left-sided heart failure is most likely occurring due to his increased systemic vascular resistance caused by his high blood pressure of 135/85. Left-sided heart failure occurs when contraction of the myocytes malfunction, compromising cardiac output, or when the left ventricle is unable to fill due to a stiffening of the muscle. Initially, the heart will hypertrophy in order to pump harder and faster so that the body can maintain a sufficient blood supply. Over time, the heart muscle weakens and grows tired due to an extra effort being produced and starts to stiffen and fail. This leads to a lower ejection fraction, hence insufficient cardiac output and insufficient filling of the ventricle. The increased pressure within the heart eventually back up into the pulmonary circulation, producing congestion in the lungs. Left-sided heart failure and COPD share the same non-modifiable and modifiable risk factors such as smoking, age greater than 65, and being overweight. Patrick's left-sided heart failure and COPD have developed independently from each other by the same risk factors. However, combined, exacerbate each other's symptoms of increased left ventricular preload, leading to pulmonary edema and decreased oxygen supply. For example, the low oxygenated blood from COPD puts extra strain on the heart, hence worsening the left-sided heart failure. Conversely, excessive fluid in the lungs due to left-sided heart failure increases the dyspnea with those who suffer from a COPD. Patrick is at high risk of developing right-sided heart failure. His symptoms are in conjunction with pulmonary hypertension and edema, such as dyspnea, coughing, and lethargy, possibly related to hypoxemia. Left-sided heart failure commonly leads to pulmonary hypertension, which is the most common cause of right-sided heart failure. With left-sided heart failure, blood cannot be ejected properly into the systemic circulation, and as a result, leads to pressure buildup in the pulmonary circulation. This leads to increased capillary pressure, dilation, and compression, which causes fluid to leak out of the surrounding tissues, thereby causing pulmonary edema. Combined, those factors lead to pulmonary hypertension and increase the workload of the right ventricle. This leads to hypertrophy and subsequent weakening of that muscle, and therefore insufficient cardiac output to the lungs. This results in right-sided heart failure. In patients with COPD, it is common to have pulmonary hypertension as a response to abnormally low oxygen levels inside the lungs. This is caused by lesions of the pulmonary endothelium that regulate vascular tone and cell growth in the pulmonary arteries due to cigarette smoke products. Pulmonary hypertension causes a buildup of pressure to the right ventricle and leads to right ventricular hypertrophy and dilation. This leads to weakening of the muscles surrounding the ventricle and thus ineffective pumping of deoxygenated blood to the lungs. Once the heart can no longer maintain adequate cardiac output into the lungs, the blood will back up into the vena cava and subsequently cause right-sided heart failure. Right-sided heart failure, most common cause is pulmonary hypertension. Pulmonary hypertension is a product of left-sided heart failure and COPD. The blood test results that will be interpreted is sodium and potassium. Hyponatremia caused from sodium and water retention subsequent from left-sided heart failure pathophysiology has profound neurological impacts that increase the risk of neuronal cell shrinkage and result in brain injury due to the development of hyperosmolality from the water loss. Loss of volume can lead to circulatory problems like tachycardia and hypertension. Patrick is not hyperkalemic as his potassium levels have not exceeded 5.5 millimoles. However, he does have a high potassium level. Patrick's insulin resistance and subsequent hypoglycemia is a transcellular shift which increases Patrick's potassium levels, as various mechanisms promote the exit of potassium from cells or impede its entrance, thereby raising the plasma potassium concentration. Potassium is critical for the normal functioning of muscles, heart, and nerves. It is important for the normal transmission of electrical signals throughout the nervous system within the body. The most important clinical effect of hyperkalemia is related to electrical rhythm of the heart. While mild hyperkalemia probably has limited effects on the heart, moderate hyperkalemia can produce EKG changes such as tachycardia, and severe hyperkalemia can cause suppression of the electrical activity of the heart and can cause it to stop. An arterial blood gas analysis would show that PaO2 is decreased as well as PaCO2 increased. Patrick's COPD decreases the partial pressure of oxygen in the blood for a multitude of reasons. The inflammation and narrowing of the airways due to neutrophils limits the amount of oxygen Patrick can breathe in, and the overproduction of mucus due to goblet cell proliferation and death of airway epithelium decreases space for the oxygen within the lungs. Increased PaCO2 results as directly related to COPD due to the decreased airway elasticity and structural support which traps CO2 within the lungs, not allowing it to escape, thus increasing partial pressure of CO2 within the blood. Decreased PaO2 levels is directly related to Patrick's left-sided heart failure due to the lower ejection fraction leading to insufficient cardiac output and insufficient filling of the ventricle. This increased pressure within the heart eventually back up into the pulmonary circulation, producing congestion in the lung, impeding the lungs' gas exchange, and decreasing PaO2 levels, thereby increasing PaCO2 levels.